You can start. I am ready.
Okay, sir.
So somebody want to start? Yogesh or Nisha? Nehal Patel is there?
No, the clarinet people will start, sir, first.
Sir, I will be giving my intro. Okay, so with all your permission, sir and ma'am, I'm starting the session. Okay.
Yeah, sure.
Good evening and welcome to all present in this session. Myself, Rupsha from Clarinet. Clarinet is very proud to be a part of this webinar as a digital partner. Now, I would like to take a minute to present a short video of Clarinet. Thank you so much for your patience. Clarinet is India's largest live digital CME and doctors-generated medical content platform. Our website is www.clarinet.com, where we have lots of live sessions conducted by eminent speakers across the globe. And we have MedWiki service, which is medical Wikipedia for doctors only, that also you can use at your leisure time. We will invite all the doctors to visit our website. So without any further delay, I would like to hand over this session to Dr. Neha Nayak, ma'am. Ma'am, kindly proceed with your talk. Over to you, ma'am.
Neha is not there today. Nehal is not there. Okay, so I will take over. Welcome, Dr. Prajapati, sir, and Dr. Ananda, sir. So we'll begin our today's session. At the outset, on behalf of my two colleagues who are the project coordinator for this, Dr. Nehal and Dr. Vaishali ma'am, it gives me pleasure to welcome you all for this session, which is always very interesting with Dr. Prajapati sir around and our experts always there to guide us. So today's session of E-Gurukul Pathshala, it's a PG clinic, and we will be dealing with the table viva on X-rays. And today to guide all our PG students, we have none other than Dr. Ananda Kesavan, a stalwart in the field of pediatric radiology. Everybody knows you, sir, and all your quizzes which are there. But for those who are meeting sir for the first time, let me briefly introduce sir. Sir is presently working as Professor of Pediatrics at Government Medical College, Thrissur. Sir has a keen interest in developmental pediatrics, and he has a postgraduate diploma in that field besides being MD Pediatrics, FRCP, and many other degrees to his credit, and also fellowships. He is the chairperson of ECHC for the year 2023-24 and has held various prestigious positions in Indian Academy of Pediatrics, starting as the National Vice President in the year 2020, past National President and Secretary of the IIP Chapter of Neurology, National Convener for IIP PG Quiz 21-22, and that's how we know you, sir. And sir has been the chief editor of the IIP Pediatric TB Radiology textbook, which is there. I think all PG students already must be referring to it. And besides this, sir is also the editor on the Journal of Frontiers in Pediatric Neurology, as well as recent advances in neonatology. And along with all these, we cannot have any session without Dr. Prajapati, sir. So it's nice to see you, sir, here to guide our students as you do for every session. And today there are our PG students who have very willingly told that they will join this session, please don't take it as an exam session. Okay, it's not an exam table viva. It is just an X-ray which sir will be taking us through. And for that, we have from GMC Bhavnagar, Dr. Bhargav. Are you there? Yes? Yeah. Dr. Chinmay and Dr. Anna are from Government Medical College, Surat. And Dr. Neha and Dr. Vinith are from YCM Medical College, which is a PG institute in Pune. So I welcome you all, and without wasting much time, I think we will hand over first to Dr. Prajapati sir to give his inputs, and then Dr. Kesavan sir will take over through the quiz, which the quiz or the X-rays which he has planned for today. Dr. Prajapati sir.
I think good evening, friends. Welcome, Dr. Anand. One more point for his introduction, if I add, he did this MD Pediatrics from Surat Medical College. So he is very well familiar with this Gujarat and even the Gujarat Medical College Surat, Government Medical College Surat. As Madam said, he's a master clinician and he's very much interested in teaching and radiology and even the neurology. And I'm sure that we'll enjoy this session with lots of even the radiological aspects. I think I'm sure that Dr. Anand must have planned, but I request all the students that be on the screen, keep your video on, and participate very freely. I think on the contrary, try to make the mistakes. That is very important, because here if you make the mistakes, probably there will be no mistakes in the exam and even in the future in the practice. So very freely, whatever you feel, if you have any question, if you have any doubt, even you may feel something, I'm sure that Dr. Anand will help us to solve it. But I wish that we should be most interactive, not only just, I will say, look at the picture and some answers, but I think, and if you try to speak over here, the exam, it becomes very easy to speak. With these words, I request Dr. Anand to start the session. Dr. Anand, please.
So, good evening. Thank you, Dr. Baldev Prajapati sir. I know sir for more than 30 years. And also, thank you, Dr. Ardi madam. And also, I would like to thank Dr. Yogesh and Nehal Patel for inviting me to share my idea about it. Today, we are discussing chest X-ray alone, both in examination point of view and also in the point of practical or day-to-day practice. So it is not a competitive exam like that, but you can, whatever things I'll ask questions in order. And if you post with just difficult question, everything is written there. So just just try to answer that. That is all. So now I share my screen. Sir, is it visible?
Yes, yes, absolutely.
Yes.
Yeah. So we start. So what do you mean radiology for PG examination? We'll ask some chest X-ray, important chest X-ray. When we are meaning X-ray, it is chest X-ray. When we are meaning chest X-ray, it is pneumonia or tuberculosis. But there, it is not like that for examination. Examination, they will give some other X-rays also. Cardiovascular system X-rays, I am not dealing with today, and GAT X-rays, bone X-ray, of course, some special newborn X-ray, spot test. And nowadays, we are keeping CT and MRI also for examination. But today, I am exclusively on chest X-ray. But they sir agree with me. In olden days, we are diagnosing each and everything with the chest X-ray alone without CT and MRI. We are old people, so we are very happy with the X-ray. But of course, CT and MRI is supported to an extent. So today I am using only 99% chest X-ray alone. So we are always keep in mind, radiological shadow often lag behind the clinical features of pneumonia. If you got today high-grade fever and this one, bronchial breathing, there won't be any X-ray shadow. It will take some time. Similarly, the X-ray shadow lag behind the clinical feature. you are not getting any bronchial breathing, child is improving, then the X-ray shadow will be there. So unless there is a definite indication for the deterioration, empyema, there is no need for repeat X-ray. So this point we have to keep in mind. So how do you start reading order? How do you start it? So my question to Neha, how do you start reading a chest X-ray?
So firstly, we'll confirm the details of the X-ray, like the identity of the patient.
Very good, excellent.
And
So
then,
first you have to, that is all. So you have to general review of the patient. Name, sex, IP number, whatever it is. Then you have to go with a particular pattern. That is important. So radiologist read X-ray in one way, cardiologist will in his own way, pulmonologist will do in his own way. But as a pediatrician, we have no complicated issue. We'll just read X-ray in order. First trachea, then we come to mediastinum. Mediastinum means we got a higher para, higher shadow, heart and thymus. Then we go to diaphragm. Diaphragm is we got the corner of diaphragm, costophonic, costocardiac angle, gas under diaphragm, dome of the diaphragm, then bone cage. Bone cage, your ribs, humerus, clavicle, subcutaneous space, and the vertebra. And the lung we systematically read. So this is the usual reading of the X-ray. So you have to identify name, age, sex, hospital number, date of the X-ray. The position markers, right and left, because sometimes they may be mistake made by the radiograph itself. They just mark erroneously right and left. And the position of the child, AP or a PA view, because there's some difference in the AP and a PA view and some quality, because and many, very rarely, we have to get a lateral X-ray, lateral decubitus, oblique view, the orthotic, some view. But all these things are not very important for us because, for example, apical pneumonia or apical fibrosis is more important for adult. In such a case, we want a more detailed examination. So usually, the simple chest X-ray, PA or AP. So AP, you have to think about two things. AP is always below 2 years. Most probably it is AP X-ray. What's the other situation? We'll take AP X-ray. Bhargav, in which situation you take other condition AP?
In foreign body obstruction.
Now, always you take AP in portable X-ray. In ICU, all the X-ray are AP view. So these are two conditions. Majority condition will take X-ray in AP view. Okay. So mediation, I already mentioned first trachea. You have to see any deviation trachea, then thymus, then hilar, perihilar, or paratracheal, subcardial lymph node, heart and vessel. That is mediastinum. Then you have to go for diaphragm, condo, costophrenic angle, costocardiac angle, gas under diaphragm. Then you have to go for bone cage. Remember, they'll keep chest X-ray for the examination. Most probably, the trapping point may be some changes in the bone. So that you have to keep in mind. They'll keep some beautiful chest X-ray. They'll give some complaint also, but the findings may be, I'll show you the X-ray also. So ribs, humerus, clavicle, vertebra, subcutaneous space, and finally the lung. What we are going to discuss today. Infiltrate, increase interstitial marking, any mass, absence of normal margin, higher program, increase viscosity. So with this idea, we'll start. Another simple approach. This is previous one is what I am following, ABCD approach. ABCD approach it is interesting to hear, but I think it may not be always easy to remember and also follow. A airway, B bone, C cardiovascular shadow, D diaphragm, E extrapulmonary, F lung field, G gastric bubble, and H hilum. But better than I think that trachea, mediastinum, diaphragm, bone, lung. That may be easy. So before reading any X-ray, there are three technical aspects should be right. Then only we can read it. First one is phase of respiration. Second one is exposure. Third one is rotation. If anything is wrong, then we won't get a right X-ray. So we'll be in trouble. So we'll underdiagnose or overdiagnose some condition. So as far as possible, because in pediatric, a small child in a dark room away from the parents, it is difficult to get a proper view, proper position. But to an extent, I think we'll get it. So we see that here I can see an expiratory view and also a rotated film. Here you can see there is cardiac enlargement is there. Totally means expiratory view. So we cannot assess everything here in this X-ray. Especially means 6 ribs, anterior ribs should be intersected the diaphragm, or 10 ribs, posterior ribs should be there visible. That is the proper inspiratory view. So here you can see comparatively normal X-ray, you can see the heart shadow. So it should be proper inspiration, ideally. But sometimes we have to compromise it, as I already mentioned. That is the first thing. Then inspiration, you can see full lung, it is visible, but in underexposure, another exposure, you can see underexposure, you can see here everything look like pneumonia. So some highlight shadow will miss. If it is overexposure, everything will be dark. So pneumothorax may mix. So exposure in space of respiration and AP view. You can see here AP view. You can see small chest and a large heart and the claustrophrenic angle. You can see some pneumonia-like picture. So when you are reading the X-ray, you have all this in your mind. When you are reading AP view, when you are reading an expiratory view, all these things should be in your mind. Otherwise, you will get underdiagnosed or overdiagnosed. How will you differentiate from AP from PA view? Of course, we already mentioned, usually they will write it there, even though it is not right. We always prefer PA view because PA view shadow not magnified. Exact figure you'll get, you won't get a large heart. Scapula away from the lung field, so you can get a better clearance of the lung field. Ribs are obliquely oriented, whereas other one is horizontally. Clavicle don't object too high in the apex, so you can see the upper lobe of the lung also. Maximum area of the lung will be visualized. So as I already mentioned, it is very difficult to get a small child in a PA view. So most probably all small children is newborn, infants, everything will be AP view, and all portable X-rays are in AP view. And the last one, technical aspects, the last one is a rotation. So as you know, there's some rotation, cardiomegaly may miss it, some highlight shadow may overlap the heart shadow. So all this will cause some misleading. Hilar and parahel lymph node shadow may be missed. So rotation also to be as far as forward. Here you can see, here you can see chest X-ray, a rotated film appears to be right upper lobe pneumonia. But here you can see it is clearly visible sail sign. What is it called? Sail sign is thymus. So here it is in a proper view. You can see the so rotation means medial end of the clavicle should be equidistant from the vertebra, and exposure means proper exposure means vertebra is just visible. APV is for vertebra for orthopedician, not for us. So these are some important technical aspects. So with these things in our mind, we'll see some important usual X-ray. Some of them are very common, but some of them are very rare. And now we'll share with our students what they are going to say. So term newborn baby with a respiratory distress, also note a cyanosis and a systolic murmur. So Anna, what is your idea about this one, Anna? Term
So
baby.
rest,
Huh?
it can be white out lung lag raha hai. So it can be MAS. It is term baby. So is there
Yeah.
any history of meconium aspiration?
But there is a systolic murmur and cyanosis also. So simple. So it is infracardiac TPVC.
Shadow.
Infracardiac. I know
Cardiac
that
shadow not
that
visible.
depth. So it's infracardiac TAPVC. And also you make a supracardiac, you will get a figure of 8. And there also some variation there. Here it is a grade 3 HMD. So it is grade 3 HMD, grade 4 you get a complete water. But it is a preterm baby. Other one is a term baby I given. So HMD staging I not go in detail, but whiteout lung in newborn. So what are the causes of whiteout? Can you say some causes for whiteout lung in the newborn?
Hyaline membrane disease, meconium aspiration syndrome, infracardiac type of TAPVC.
Okay, so you may get a TAPVC, that is infracardiac TAPVC, pulmonary hemorrhage and pulmonary edema, congenital bilateral pneumonia, stillbirth. If child is not taken any breath before that one, laryngeal tracheal atresia, we have some X-ray there also, and the congenital lymphangiectasia. So complete whiteout, you are thinking about all this possibility. So means everything you got some DD, and you can say, we cannot definitely we can say. So with the favorable history and as far as possible clinical clue, you can reach a diagnosis. So here it is very simple. What is this one?
Effusion.
Right sided.
So Bhargav, what is this one? I have noticed so
Right.
simple X only.
Right sided pleural effusion.
Yeah, here
Pleural
child got
effusion.
bronchial breathing and also dull note. So what is your inference there? bronchial breathing and dull note.
Right, sir.
Right, pleural effusion.
So here you can see, here it is pleural effusion, it is true, but it is mediation is not much shifted. The shifting of the mediation is not much, and the postophrenic angle is here. So it is pneumonic effusion with the history of bronchial breathing and the minimal effusion. It may be pneumonic effusion. And again, so you have to think about it just like a statistical mathematical calculation. You have to go in that order. Pleural effusion, okay, but that much of mediation shift is not there. As I always mentioned, bronchial breathing is there. So you have to clinically you have to correlate. That's important. The pleural effusion X-ray features. Vinith, can you say X-ray features of pleural effusion? Simple question.
There would be obliteration of CP angle, sir. Then second would be there will be contralateral shift of the mediastinum. There will be diffuse opaque shadow seen on the along
It is
with
a
the
1, 2, 3, 4. This is a simple 1, 2, 3, 4 means a uniform homogeneous without any aeobronchogram. In pneumonia, you'll get aeobronchogram in good film, but homogeneous opposite. Obliterated postophrenic angle and the mediation is shift according to the severity of fluid and the LES curve. I think you all know LES curve, highest line in the maxilla. So because pleural effusion will be visible. If there is a postophrenic angle, then it is 100 to 150 ml. And the early detection, minimal effusion lateral decubitous is ideal. And by the time they will come, it will be too late. So half hemithorax 1000 to 150 ml, 1500 ml, and the end hemithorax 2500 and 300 ml old children. So be about re-expansion pulmonary edema, because when you are aspirating the pleural effusion too much, you should be very careful. And also you should know guidance for treatment of emphysema. That will they will simultaneously they will ask for examination. What is the guidance? What is the light criteria? So they will ask for that such things. So you have to be very thorough with such X-ray when you are there showing. They will ask such questions. It is 3.5-year-old child. I think now we'll ask to Chinmay. A recurrent respiratory tract infection. Taken 3 courses of antibiotics also, and fully immunized. So it's X-ray. So Chinmay is there?
Yes, sir.
Just interact. So you are seeing some shadow. Which side is shadow?
Sir, it is on the left side.
Yeah, it is a pneumonia.
Sir, is a consolidation patchiness is there, and CP angle could not be appreciated.
So you do a critical review of the X-ray. Here, what is saying? You are a non-uniform shadow on left side, and the gross mediation shift is there. And this shadow, it is not a pneumonia, it is not a uniform shadow, it is not a pleural effusion, it is something else. Here we are coming the help of a mediation shift. So it is what I say. We got a 3-4 X-ray of the same patient, then we got a something else, we got a diagnosis, we are taking MRI, it is a diaphragmatic hernia. Remember that when a newborn presenting with a diaphragmatic hernia, we are very much aware of it. But when a 3.5-year-old, when a 10-year-old boy, when a 20-year-old man, so you'll be get confused. So this child, because when they are presenting late, the prognosis will be excellent. The child underwent surgery and it is very, very good. So my question is that what is X-ray feature? Chinmay, what are the X-ray features of a congenital diaphragmatic hernia? We want 4 features. 1, 2, 3, 4. So everything it should be very in a mathematical fashion. Radiology means mathematics. So you have the pleural effusion, 4 findings. Diaphragmatic hernia, 4 findings. So what are the X-ray findings in congenital diaphragmatic hernia?
Sir, mostly, sir, ipsilateral side, left side, it would be diaphragmatic shadow would not be visible. There would be a collapse of the lung seen on that side, ipsilateral side. Bowels of loops with air into it would be seen. And there may be contralateral side shift of mediastinum.
Okay, good. So absence of stomach shadow. So always you look at dome of the diaphragm, whether dome of the diaphragm intact or not, and can you see the diaphragmatic shadow below the diaphragm? That's very, very important. Once level, it is very useful. Not only for identify left or right, stomach shadow is very important. Usually we are not giving much importance to stomach shadow. So in dextrocardia or something in the diaphragmatic hernia, then loops of intestine in the chest, diaphragm, you get a dome of the diaphragm is interrupted and desktop position of the heart. And 95% of the diaphragmatic hernia is on the left side, but 5 to 10% you may get a right side also. In that case, you may miss it. Okay, we'll go to the next case. So pneumonia, I already mentioned a guide to radiological diagnosis. Clinically, we have to diagnose, then we have to take X-ray because we are because culture report, it will take a long time or already given some antibiotic, so you won't get any chest X-ray. So either you have to go by age because below 2 months, 2 months to 2 years, above 2 years, or school going children, this much of this pneumonia, mycoplasma pneumonia, whatever it is. Or you have to go by X-ray picture because we are culturally very, very backward. So we have to depend upon history, age, and X-ray. So we got some certain pattern because viral pneumonia, bilateral hyperinflation, segmental atelectasis, interstitial infiltrative. That diaphragmatic hernia, why we are saying it is not viral pneumonia, it is only unilateral. A viral, you make it most probably bilateral because this COVID season, RSV infection, everything we are seeing bilateral shadow. Mycoplasma, you make it any type of. Usually we say it is a walking pneumonia, but recently we had 2-3 cases of severe pneumonia due to mycoplasma also. And the acute lobar pneumonia, pneumococcal pneumonia, very fond of. If it's a pneumococcal pneumonia, as a government medical college doctor, I am very happy with the crystalline penicillin. But the Prajapat sir also agree with me. Olden times we are very happy with the CP, but now CP is not available also. Right upper lobe repeated, it's may baby in the newborn or bedridden child, you have to think about aspiration pneumonia, right upper lobe pneumonia. Upper pneumonia with the cavitation or bulging fissure, very characteristic of Klebsiella. And recurrent right middle pneumonia, you have to think about some lymph node pressing, endobronchial, extrabronchial, most probably tuberculosis. These are some guidelines. What about TB? So pneumonia, again, bilateral pneumonia with immunodeficiency, you are thinking about pneumocytic irony or lymphocytic interstitial pneumonia. Multiple small abscesses, staphylococcus pneumonia, Klebsiella, and tuberculosis. What is the X-ray finding of tuberculosis? Can you say some X-ray findings, Anna? Can you say some X-ray finding of tuberculosis?
If it is a chronic case, it can present with fibrosis, miliary TB, multiple miliary node-like lesions can be seen bilaterally. It can be bilateral. It can even present as bilateral hilar lymphadenopathy. It can present as bilateral interstitial infiltrates also.
So very good. So we'll go to. So what is the problem here? It's not moving. So X-ray test, whatever she told is right, but LR lymph node, hilar, paratracheal, subcanal. But there are so many conditions. You are getting all these conditions. You may get in a sarcoidosis, pneumonia. You may get a lymphoma, leukemia. Everything you get it. Pneumonia and bronchopneumonia not responding to conventional antibiotic. You have to think about this is one condition where the empirical AKT. Unilateral piliation, bilateral piliation, you may get some other condition. Cavitation fibrosis is very unusual in pediatric age group and immediately remotely. So you have to suspect when pneumonia is proper antibiotic. So my question, there are 3 chest X-ray features of registry of pneumonia. What are 3 X-ray features? NTEP. RNDC is turned to be NTEP.
Parahilar lymphadenopathy, fibrocavitatory lesion, and miliary mottling.
Very good. So if we call it lymph node, miliary, I am not going in detail. So all that signs are whites are not pneumonia. We have seen one diaphragmatic hernia, we have seen mother shadow, and we'll see so many X-ray like that. All whites are not pneumonia. That you have to keep in mind. So here you can see a 9-year-old male, fever and cough of dyspnea 7 days. Fever, cough, dyspnea 7 days. Facial puffiness 2 days. Now we'll go to Neha. So we start reading X-ray simply. Neha is there, no?
Yes, sir. So this is
Neha?
a yes, sir. This is a chest X-ray PA view, where we can
For our discussion, you need not say chest X-ray, PA, AP position. You need not to say now.
Okay.
Everything is chest X-ray.
Okay.
So we can save time. Okay, chest X-ray. Everything is chest X-ray.
So here, sir, we can see a enlarged mediastinal mass which is occupying almost entire left hemithorax. There is in this situation,
Why you are saying this in mediation? Why can't it be it pleural effusion? Why can't be it large
Costophrenic
pneumonia? Why can't be it agenesis solang? Why can't be it? So what are the DD of uniform opacity on one side of them. So what is the explanation for the media channel?
Massive pleural effusion, cardiomegaly, like large cardiomegaly, and
Okay, very good. Anyway, her diagnosis is very wonderful. You can see here one factor, facial puffiness, 2 days. That is mediastinal syndrome. So why can't we keep pleural effusion? If it is a pleural effusion, you can see that the costophonic angle is not obliterated here. You can see some black shadow here. And the media is not hardboard. In this such a large media pleural effusion, you get a mediation stripped, but it is hard. Here, hardboard is not clear. It is not right atrium. It is something else. So if it is a consolidation, why there is a some shift in towards the right side. So you have to go in that way. So actually, it is a case of NHL. It's right. Mentioned it is a case of a mediation mass. Then we are given you got breathlessness. So some other features of the respiratory compromise. So we are given immediate chemotherapy, and suddenly it is reduced. So patient is because we got so final diagnosis NHL but SV syndrome, but she got what complication you are expecting here, Bhargav, when you are treating such a large mass with this, what are you complication expecting? Huh?
Tumor lysis syndrome.
Very good, excited. So this patient also had a tumor lysis syndrome. So it is up to 7 days of treatment. You have to keep in mind, you may get hyperphosphatemia, hyperkalemia, hyperuricemia, and hypocalcemia. Everything is hyper except calcium hypo. And you have to treat hydration, alkalinization, allopyrinol. And now we got a raspberry case. So, Bhargav, can you say mechanism of raspberry case? But just keep in mind, I don't go into detail because it is a recombinant urea oxidation. So we got a very good experience with this drug also, very good, very effective. So each child got on and cough. So you can see some fluid level. We tried aspiration, 1 or 2 X-ray of the same size. So what we can do, because we got this much of shadow. Anna, further any procedure, Anna, anything in your mind? I can see any. So I understand. You just put the rice tube. So you can see the shadow here. So just put the rice tube, this stomach only. So it is eventuation of diaphragm. So such a simple, tricky procedure, you'll get a diagnosis. Because the thing is that when we are there, USG and everything is not easily, very quickly available. So it will take some time. If it is Saturday, Sunday, you want to get some problem like that. So you put a rice tube. You can see the mediation shift is to stomach to eventuation of diaphragm. Okay. So it is another eventuation. So you can see right side eventuation not very common, but it's eventuation and lateral X-ray. So here I want to stress we are not much utilizing lateral X-ray. I think Baldev sir also agree with me. We are not very expert also. We are not utilizing lateral X-ray also. I think it is one area we are to very, very useful. So you can see it is eventuation diaphragm, small eventuation. It may be congenital, it may be acute, it may need any treatment. Sometimes small eventuation not need any treatment, or large eventuation may treatment. So what I want to say that here you can see very interesting case, 6-year male recurrent fever, loss of weight. You can see large shadow here. If it is a serious case, you can see tricuspid atresia, Epstein anomaly, something like that. But being it is a respiratory case, we can see that a large shadow. So how to approach it? So simple. You take a lateral X-ray. It is just a middle lobe, middle fissure effusion. It is TT. AKT we are taken, child is improved. So that is power of your lateral X-ray. So you should utilize it, especially for mediastinal mass. Mediastinal mass, everything we are not covering too much. So mediastinal mass, upper lobe mass. So here lateral X-ray will collapse everything. It's very, very useful. So whenever you're getting confusion, take lateral X-ray. So here it is the importance of lateral. It's something very dangerous hearing, but it is simple. It is just taking it's a kid like that. So that is the importance. So in the lateral view, you may mistake for something else, but in the AP view, you're very clear that the tiger is taking its kid. That is so. So that is importance of lateral X-ray. Here it is a symbol. What is it? Hydronomothorax, nothing more. And what about 80-year male fever and cough 1 week? acute onset of fever and cough. What will be it? Chinmay?
Yes, sir. So there is a opacity on the right side,
Yeah.
obliterating the schizophrenic angle.
Yeah.
It appears to be towards some mass or
So here it
collection.
is very rightly mentioned. So you can see that the name of the sign. Any sign
Felsen.
helpful to you, Neha?
Felsen sign.
Very good. So
Silhouette
it is a
sign.
Felsen sign. So whenever there is a right cardiac border obituary, right middle lobe, right from right lower lobe, left cardiac, left. So it is still outed. It is not silhouette sign. It is as she rightly mentioned. It is
Felsen
Felsen sign. Here we got a right lower lobe side is silhouette. So it may be, and the diaphragm also not visible. So it may be right lobe pneumonia. Very good. So you have to take a proper history, sudden onset, some history of foreign body injection, something like that. Somebody mentioned about a foreign body injection at the beginning. So I think you have to think about it. So again, here left lobe collapse. Here again, left lower part, middle part is still hot. So it may be that part, it may be collapsed. So 12-year-old boy with the Pattambi, places in my Kerala place, don't worry about the place. And fever of 3 weeks duration. No malnutrition. She's very, actually she's overweight, 42 kg. No family history of TB. All routine investigation normal. Mando test negative. CB that it was not available at that time. It is around 3-4 years, 5-6 years back. So this is X-ray. X-ray. What is X-ray? Neha?
X-ray appears to be
Huh?
normal.
Not visible. This is
Different
a bilateral medullary shadow only.
Hmm.
So we have done gas. So it's a medullary shadow only. So the thing is that we tried a gastric aspirator, except CT, everything we tried. But everything is negative. Mando is negative. She's very healthy. No history of contact. So one more test examination confirmed our diagnosis. Which examination will give direct, where you can see TB directly with your naked eye. Which area?
Eyes.
Yeah. So it is a coronal tubercle. So once in a while, such a clinical, a sixth sense will help you. The patient got no other evidence, chest X-ray clearly showing miliary shadow. We roll out all cause for miliary shadow. So finally, we just send the case for ophthalmology. A beautiful bilateral, you can see multiple coronal tubercle. So such a things, once very rare clinical findings will help you to diagnose where other things are failing. There will be some point somewhere. You have to find out that point.
Dr. Anand, should I make one point?
Yeah.
I think particularly to the students, somebody may ask in the exam that like here, suppose some shadow which you are suspecting miliary-like shadows, but you are not clear. And suppose by chance if you get in the fundus, these spots, it's well and good, but hardly it is seen. In that situation, is there any other modality which will probably help you to confirm these miliary shadows? Routinely, which we don't advocate in the pediatric practice.
Bronchoalveolar lavage.
Of course, bronchoalveolar lavage we'll try to get this any evidence of microbiological diagnosis. I'm asking the radiological diagnosis.
CT.
Yeah, usually we don't advocate the CT thorax or CT in the children due to this radiation. But if you are having, there are very few indications where you may go for the CT thorax in the children. One is the suspected unproven biliary shadows. Is there any other condition where the CT may help you? Commonly we go for the very, very rightly Dr. Anand is insisting that X-ray test is quite useful in the different modalities. And even ultrasound is very good help, particularly for the fluid and other things. But very few situations where CT may be helpful. One is biliary. Is there any other condition where the child is febrile, toxic, following this pneumonia, some complication has developed, and you want to confirm? and even the child had got the clubbing within short time. That clinical condition. I think here which I wanted to give you, always all these radiological shadows should be interpreted with a reference to the clinical picture. Never jump from this radiological shadows that this is the diagnosis. Because with the clinical history and examination, it will be totally changed. So it's very important. Here I am giving that the child who was having this very high grade fever, respiratory symptoms, it was diagnosed pneumonia, developed some complication. Now the child is having even the clubbing within the very short time, toxic child, very high grade fever, and once even mother complain of hemoptysis.
Bronchiectasis.
Bronchiectasis.
Okay, one is bronchiectasis, but bronchiectasis takes more time.
With
Here it had
endobronchial
developed within few hours.
endobronchial
It's a lung problem related to the problem of the pneumonia.
Lung abscess.
lung abscess.
Lung abscess. And in lung abscess, even this, if it require, the CT will be more useful. Usually we go for the sonography for fluid and other things, but in necrotizing pneumonia or the lung abscess or miliary shadows, you may have to go, or even some congenital malformations like bronchogenic cyst or pulmonary sequestration if you are suspecting, probably you may go for the CT MRI. You know that nowadays available this modern investigative facility when we should use, that is also very important. Many a times we just jump because it is available. It's also not right. Please, Dr. Allen, take it further.
Sir, you can interrupt any time. I am just
No,
going
no,
autonomously. I forgot to ask
it,
you.
it is
any
it is
comments.
going on. It is going on very well, very well.
No, you can give any comments any time, sir. I am very,
Yes, sir.
very happy about this topic. That is, I am very.
Absolutely.
And also students can also intervene.
Yeah, even students should ask the question. Suppose you may differ even, or if you have some doubts, I'm sure that interactions and discussions will, all of us will learn more.
Yeah. So we'll continue, sir. We'll continue.
Yes, sir. Please.
So miliary modeling DD we already mentioned it. But miliary modeling when you got miliary tuberculosis, then bronchopneumonia, or it may be viral pneumonia. You have to keep it. And nowadays we are seeing more fungal infection also in the ICU, and pulmonary infection, not very common, but interstitial lung disease. One thing you have to keep in mind. So such things you have to keep in mind. And a highly member disease, and you are seeing tropical eosinophilia is also in adolescent. We are getting cases like that. And the aspiration, bilateral aspiration pneumonia, or may get miliary shadow, and histiocytosis, pneumoconiosis, and hemosiderosis. All this condition, for completion sake, I mentioned all these causes. Once in a while, exception, they may show, sometimes they will ask like this one. Anu, 6 years female, recurrent respiratory tract infection, and since birth. So now we'll question to Vineet. This is Anu. Anu is now, I had seen her very early. Now she is completed her BCom, but you can see this X-ray. So now we are concentrating uniform opacity one side. We are seeing mediastinal shadow, now this shadow, pleural effusion. What is this one?
So there is uniform opacity on the left side of the X-ray. Most probably, and there is also blunting of CP angles, and
so here it is a long duration from birth. So here it is what is a herniation of the right lung, and here volume loss here. So most of it is a agenesis of hypoplastic left lung. Here you can see hypoplastic left lung here, and it is a herniation of the right lung here, and it's hypoplastic left lung. So here it is another reason for the opacity on one side, and after surgery, you can see that the only idea of surgery is that the hypoplastic lung will be a seed for the infection. So by surgery, that hypoplastic part, a child will get improved. And as I already mentioned, now she's completed her BCom. She used to get a recurrent infection. She underwent surgery. So uniform opacity one lung. So fever and cough for 1 week duration. It's just choking while playing. So I think simple X-ray. Neha, what is this one?
So this shows hyperinflation on the right side with
We see the history, choking while playing.
foreign.
So
I
Foreign
think
body.
I think Neha, if I am examiner, I may ask the question in some other way. With this history, what you are expecting to see in the X-ray?
You just go in
I
the,
think
what about trachea? First
if-
trachea.
shifted.
What's trachea? Trachea grossly shifted. Trachea is here only. And here it is totally collapsed. So it
Collapse.
is foreign body, total collapse of lung. So you have to go that way. The reading order should be there. You have to give importance to history. Then you have to analyze your history and you have to correlate your clinical findings. So history of choking, trachea shifted, collapse lung. So it is a
Foreign.
Foreign
They-
body.
foreign
they-
body collapse. Okay.
Neha, is it a partial obstruction or complete obstruction? The previous X-ray, the foreign body can cause both the type of obstruction.
It's a groundnut.
Complete.
No, my point is, where is the foreign body, right side or left side? Which bronchus?
Right.
Left bronchus.
Left bronchus.
Left bronchus. Okay. And then what you are able to see on the right side? What are the
Hyperinflation.
findings?
Hyperinflation of the right.
What is the hyperinflation? Anything else? You can compare the distance between two ribs on both the sides. Very nicely seen in this X-ray. If you see, the distance between two ribs on the right side is more. You can simultaneously see on the left side.
Crowding
Right.
of in the left.
So, yeah. And
Crowding
second
in
thing,
left
see the right dome of the diaphragm.
flattened.
Totally flattened due to the
Flattened.
hyperinflation. And suppose this history is there of choking, and very, in the foreign body it is said there will be the hyperacute history. What is hyperacute? Previous moment child is normal, and next moment very bad cough, that is choking, without any other symptom, fever or anything else. And you are highly suspecting, suppose foreign body, but your chest X-ray is normal, Neha. What you will do? Your chest X-ray is reported as normal. You don't get any evidence of foreign body. Now what you will do?
Bronchoscopy.
Why? Because parents say that the X-ray is reported as normal. There is no foreign body. Why I should go for the bronchoscopy with some calculated risk in my child?
X-ray might take some time for, if it is a partial obstruction, the changes may take some time to appear in the X-ray. X-ray can lag.
Dr. Anna, it is a mechanical problem. A mechanical problem will develop immediately. It will not require the time. Infection will require some time. Inflammation may require some time. Cardiac disease may require some time. But any type of the mechanical problem will not require the time. The point is, almost in 40% X-ray foreign body cases, X-ray may be normal. So normal X-ray does not exclude the foreign body. And suppose if you have the sufficient background, always go for the bronchoscopy. Right. So that please keep in mind. Dr. Anand, please take it further.
Okay, sir. So now it is another cause for the uniform opacity. Now we'll go to next case. So here what is this word? Anna.
Sir, it's again, right side of lung is completely opacified almost, but there is no blunting of CP angle seen. So, and trachea is central.
This is a pleural effusion, I think. Now, what are the cause for
Pleural
unilateral? We already covered what are the cause for the unilateral lung opacity to Bhargav. We already discussed. Just enumerate that one. Bhargav.
Pleural effusion, empyema, and foreign body obstruction, and
Foreign body obstruction means a collapse, total collapse.
collapse
Hmm.
with agenesis,
Yeah.
lung agenesis.
Yeah. So we rightly mentioned. So immediate pleural effusion, pneumonia, large pneumonia, agenesis, pneumonectomy. Also, you have to keep in mind and a collapsed lung. But I'll show you another case. 4-month-old from male child, severe breathless from 1 week of age. history of excessive crying during feeding and passing through, history of mild fever, angina, everything is normal, and a dyspneic axillary muscle involvement, pallor present, tachycardia, sweating, low volume pulse, no sinus or clubbing. Respiratory system, right side normal, left side no air entry. Tender and soft hepatosplenomegaly. Cardiovascular cardiomegaly, systolic murmur grade 3. But since there is a fever and tachypnea, tachycardia, anemia, systolic murmur, we diagnosis as pneumonia is X-ray. So here you can see the not mentioned like that uniform opacity one side. You can see large shadow on left side, heart shadow not visible, lung shadow not visible. As I already mentioned, we are not getting any air entry on left side. So this is a very, very rare case you can diagnose. So routine exercise hemoglobin 8 gram, chest X-ray, cardiomegaly, left lung not seen. So here we got some clue ECG. So what is ECG here? Anna, ECG here. I think one field where we are lacking some confidence ECG. So we should know routine ECG, axis, LVH, RVH, major change. This is one condition you can the diagnostic. You can diagnose this heart disease with ECG alone.
Please remember, Dr. Anand has given you the hint. It's a problem since almost birth. And now even he has given the clue that apparently looks some shadows on the left side, but it's a cardiac problem. And even he has mentioned that the cardiomegaly was there. And even perspiration, that means child is in cardiac failure. And even the liver also he has mentioned enlarged and tender. So what type of, and you probably had mentioned child is irritable. Irritability is due to what?
Anybody can answer. What is it?
Right heart failure. Right heart failure.
Irritability.
Right heart failure.
Which type of these conditions will give the quite irritability to the child? Not just crying. It's quite irritability.
So can somebody read X-ray or ECG?
In other way, if I give the idea, which type of the pain is severe, which you cannot tolerate? Vascular pain or ischemic, absolutely. And what is the cause for ischemia in this patient? And now what Dr. Anand says that look at the ECG. ECG, whether are you able to see anything?
ST. T-wave inversion.
Yeah.
T-wave
What's it?
inversion.
Not mentioned. So
T-wave inversion.
it is equivalent to myocardial infarction in adult.
Yeah.
So we can go back to the
T-wave
history.
inversion.
Tachycardia, sweating, cardiac failure, everything is there. Now just see the ECG. One AVL, I shown the lateral lead and one AVL. So here you can see that a deep T wave and a T wave inversion. T wave here. So it is very diagnostic by ECG alone. So deep T wave, one AVL and HC sigma changes and it is a anomaly alpha. It is alpha alone. So such a features means you have to intervene very early. Very simple surgery, palliative surgery very simple, but you have to intervene very early. Our child, when we are seeing 70% ejection fractions reduced to 70%. So you have to diagnose it early. This is a one condition you can diagnose periphery. High index of suspicion, if you are taking ECG, you will get a equivalent to myocardial infarction. This is only some condition what we can do. So it is one. So after treatment, we are given some treatment and the child improved the decongestion measures. You can see the heart size now reduced. So it is fully occupied, previously fully occupied. So just I showed that this is CVS X-ray because uniform opacity one side rarely may be due to large heart also. Actually, I don't want to show any cardiac case today, but just because of the large heart occupying complete hemithorax. Now you can see that heart size is decreased. So this child, after that, again recurrent cardiac failure, child died. So this is the things you have to keep in mind. Very, very rare condition.
I think just for the sake of the students, you know now ECG, as Dr. Anand said, is absolutely right. We are neglecting. We don't look at the ECG, we don't go for the ECG, or probably we are not trained how to read it. But in the exams, and particularly even the DNB, in the station, they keep the ECG. And even here also, somebody may ask the questions of ECG. In which condition ECG diagnostic? Other modalities may not be able to help you. Only the ECG will be diagnostic. Can you mention some conditions?
Arrhythmias.
What is arrhythmia? Which arrhythmia is common in the pediatric practice?
Supraventricular tachycardia.
SVT.
Okay. Any other, supraventricular and all these can be the part of some disease, but very classical, which may be even life-saving if you diagnose. Complete heart block.
Beating. Okay.
Even in the
Heart.
newborn, you can go for the
block.
pacemaker, implantation, and child can be saved. You can diagnose even WPW syndrome, aberrant conduction pathway. You can operate and child can be
QT
saved.
syndrome.
So these are
Long
the
QT
conditions.
syndrome.
So absolutely. Prolonged QT syndrome. Absolutely. Only ECG can diagnose it. So some conditions, and even nowadays in intensive care units also, that there is continuous CC monitoring. That you should know that how the hyperkalemia, hypokalemia, and all the things can be diagnosed. I think we are deviating from the X-ray, but I thought that this is very important to sensitize you. Dr. Anand, please take it further. Sorry for interruption.
Yes, sir, rightly mentioned. In heart block and everything, you will palpate pulse, you will feel something different. But here, the thing is that the pulse will be usual rate and everything. You have to take an ECG, otherwise you will miss it. Sir, can we proceed?
Yes, sir. Please.
Sir, we can stop any time.
No.
We can stop any time.
I think it's going on very well. Very well.
So 2 weeks old term baby, which is respiratory distress, is X-ray. What is the diagnosis? We need it.
So here, sir, the cardiac shadow is seen on the right side, and cannot see your track here.
So here I can see some absence of lung marking on left side.
Absence of lung marking.
So it is congenital lobar emphysema. That's the thing is you have to keep. So two common congenital anomaly. One is congenital lobar emphysema. Second one is lobar emphysema. What is this one?
CCAM.
Huh?
Cystic.
Congenital
Pulmonary.
pulmonary
Pulmonary malformations.
No, it is a cystic adenoid malformation, CAM. So it is CAM because diaphragm is intact and the clinical feature is a 2-3 weeks old child. So it is cystic adenoid CAM. So it is a case of a CAM. So these are the two common. We get so many other congenital anomaly also, but the CAM and congenital lobar emphysema are two things. I think students are not very much aware about that condition. When we are students, we are very much aware. Nowadays, I think somehow these things are not there mind routinely. But when we are students, it is very there. So acute dyspnea while playing. So what is this one? Bhargav, you can take it. Acute dyspnea while playing. If you go to 2 X-ray, this is one condition where an expiratory X-ray is indicated. So always we prefer inspiratory X-ray. But here we are preferring expiratory X-ray also.
Staple sign.
No.
foreign body.
Staple sign.
Foreign body. Which side? My question is which side?
Right side.
Right side.
Right side.
It is not right side. It's right side.
Right.
It's
You can look
right
at the
side.
It is strapped there, so it is right side.
Right
It's a
side.
ball and ball type. Other things not like so. After removal of foreign body, both side is equal. So one side air is gone, other side it is normal. So it is a right side foreign body. So all other X-ray inspiration only in foreign body some indication for expiratory X-ray. Say acute onset dyspnea. What is it? Simple.
Pneumothorax.
Pneumothorax.
Pneumothorax. 3 findings. Pneumothorax 3 findings.
collapsed lung margin.
Yeah. No air
Collapse.
marking.
Bronchomartin.
Collapse lung.
Yes,
mediation
tidal.
shift.
Yes,
And of course, it will be
Blackout lung.
acute dyspnea. And the only thing is that sometimes you'll get a narrow, mild pneumothorax. So in that case, you will miss it. This much of gross collapse and large, this one you want to get. Sometimes you get a narrow, minimal pneumothorax, then you may miss it. We'll go to next case. So you get increased lucency, as you mentioned, unilateral pneumothorax, obstruction due to foreign body, large bulle, compensatory emphysema, mastectomy. Mastectomy is one syndrome you have to think about it, and a Poland syndrome. It's severe pneumonia. Severe pneumonia. So it may be Sir mentioned about necrotic pneumonia. Severe pneumonia. What you are seeing here, multiple pneumothorax. So organism I am not mentioning here. And here multiple abscesses. They coalesce. So it is a very serious patient. This patient got a deep vein thrombosis also. So it is serious staphylococcus infection. Multiple this one. And such a child. So if you are seeing such an X-ray in the beginning itself, you should be very, very careful. This stage, after this one, it is maybe progress that much. So when you are seeing X-ray in this stage itself, you have to take very care. You have to start with the hit hardly. And then multiple, then you can see further progression. Patient improving also. So child got a deep vein thrombus also. You can see literature, staphylococcus, such a pneumonia may be associated with the deep vein thrombosis also. So, yeah, that was a very good X-ray. A common agent, how will you treat? I am not going. So it is a terrible person.
Can we go back to the X-ray, please, sir? So is it like a hydropneumo or pneumothorax? The pneumothorax also here?
If you are seeing this X-ray alone, you can suggest like that. But one from by starting like that series of X-ray here, you multiple abscesses, it may multiple abscesses, pneumatocoeli, multiple abscesses, the fluid level. If you are seeing this X-ray, you can say definitely. But if we are getting 5-6 X-ray of this type, I have only kept an intermittent X-ray only because lack of time. So you can, if you are showing this time, you can say multiple fluid level. You can say like that. No, it is well accepted.
I think here one common question with somebody may ask in the exam also. If probably the examiner has the X-ray.
Yeah.
That it was the necrotizing pneumonia, likely the staph, as Dr. Anand was showing. Detailed very efficiently with these effective antibiotics. Clinically, patient recovered total. But the X-ray shows some persistent still pneumatosis. How will you manage? What you should do? Dr. Vinit? Suppose as I said, even it was necrotizing staph pneumonia, effectively treated. It was very bad patient on admission. But fortunately, now it has recovered totally. Afebrile, playful, taking orally, but the X-ray showed persistent pneumatosis. What will you do now? How will you manage?
We'll go for if the child is showing
I will give the options. Should I continue the antibiotics? Second, should I go for insertion of the tube to remove this pneumatosin? Third, should I go for the surgery to remove it or something else? Now you can answer what you will follow.
The child was improving on antibiotics, we can continue antibiotics. But if pneumotosis
already 3 to 4 weeks completed, count has also come to normal. Acute phase reactants, ESR, CRP normal. What is your idea of continuing the antibiotics? Because patient has recovered, blood, all the acute phase reactants normal, count is normal.
Yes.
What else you say?
We can go for them surgery to remove the pneumatosis.
What surgery? Okay. Neha, what you will do? Suppose you are treating person, they have come to you for second opinion from Vinith. Because Vinith advised surgery. And you know the parents will go to the next person. So now what you will do?
So if there is just a single pneumatocoel left, we can just insert the drain and remove it.
What is my idea? What drain I will put?
Intercostal.
So tube insertion.
Tube insertion.
Again the patient went to Dr. Adna because one is asking for the tube, second is advising for the surgery, and parents are worried. Child is playing. Dr. Adna, what you will do now? You are
If
the
the
third. You are
patient
the
is
third.
clinically stable and improving, we can wait.
What you will, but they say at the same time that the problem is there in the lung. Suppose something happens to my child, are you responsible? You are taking the responsibility, Anna? They will ask you. Why I am telling all these questions? Because these are the most practical. Right? And we should be able to competent enough to answer it. Reason is, I think already from the beginning, Dr. Anand said, radiological recovery always lag behind the clinical.
Behind the clinical. So wait
Here clinically patient has recovered, but you know what destruction has place, what lung tissues have been destructed, recovery requires some time. Pneumatocyst does not require anything. No insertion of tube, no surgery, no antibiotics. Just follow up within few months it will recover. But the only one point, what I should advise them, I should give the one word of caution to them.
Avoid excessive activity, avoid contact sports.
Okay. Suddenly the child becomes breathless, they should run. Because pneumothorax is likely. So only you can explain and put on the discharge card that parents are explained for spontaneous pneumothorax, then they should come back, otherwise follow up for the good recovery. Right. So pneumothorax does not require the treatment, but I think we should know. Thank you very much, Dr. Anand. Take it, please.
I will proceed, sir.
Yes, yes, please.
So it is a child with a cerebral palsy, recurrent pneumonia. It is usually seen what we are seeing it regularly. So cerebral palsy patient, there are only two reasons for admission, recurrent admission. One is seizure, second one is aspiration pneumonia. There are so many other things are there, but these are two main reasons that you have to keep in mind. So I can see here it is a aspiration pneumonia. Important thing is that you have to keep the level of the fissure. So here fissure is a normal level, so it is a consolidation alone. If the fissure is pulled upward, then you can say it is there is a collapse also.
Collapse.
So here it is a pneumonia again, and here you can see it pulled upward. So it may be a collapse consolidation.
Collapse.
So lateral X-ray will give some clue, and you have to keep in mind everything. You have to keep in mind the lobar fissure, the level, everything you have to keep in mind. So it is a 4-year-old male with a recurrent pneumonia. He got recurrent pneumonia, respiratory infection, father suffering from TB. On exam, dyspneic cyanosis, clubbing, chest X-ray. I shown the diagnosis also. So it is a pneumocystic kind pneumonia. It is a first case of it's a very old case. Nowadays we are not seeing. So it is PCP pneumonia. The child admitted several times. Father, mother expired. Now he admitted later. It may be LIP pneumonia. So LIP pneumonia, the treatment is steroid. Whereas PCP pneumonia, you have to give sulfur drugs if possible. So these are the olden days. Nowadays we are not seeing it, but just what I kept it.
Yeah. Just a word, Dr. Anand, before you go further, for the students. You know, clinically, if you see that the child may have the respiratory symptoms, particularly there is a hypoxemia, SpO2 is low, or even sometimes cyanosis, which is long-standing, maybe the clubbing. But if you examine the patient, there are minimum chest size. Minimum chest size. In this type of condition, always think for the interstitial problems. There is a disproportionate hypoxemia or cyanosis to the chest size. And then interstitial disorders, miliary tuberculosis is the best example of interstitial disease. Second thing was already Dr. Anand showed that pneumocystis carinii is the interstitial type of the pneumonia. Or even the sarcoidosis, what you get, that is the interstitial disease. So I think we have the very limited interstitial disease, but this is suppose your clinical observation, then probably that will help you to catch the diagnosis. Dr. Anand, please take it further.
Okay, sir. So nowadays we are not seeing, but previously we got a maximum number of cases in Kerala, in Thrissur. Okay. So here, a congenital silent heart disease with high grade fever. So very simple X-ray. What you can see here? A lung abscess. You can see lung abscess with the fluid level. Yeah, what is the findings you are seeing here, Neha?
Again, some multiple abscess
Yeah, you can see two abscesses.
Two
When you are
abscesses.
not happy with one
One
abscess,
over the left.
yeah, another abscess is here.
Right. Yes, sir.
So when you are getting one finding, look for another finding. If you are getting one murmur, look for another murmur. So don't happy with it. If you are getting some CVS murmur, look for respiratory system, something like that. So don't always happy with a single finding. You look for other findings also. Not always true, but you are look for it. The 4-month-old from Palghat, noisy breathing 1 month, and a reassurance. Noisy breathing, it may be laryngeal and this one. So what is a Chinmay? This one, 1-month-old child.
Looks like a circumstance mass on the right sided upper zone.
A 1-month-old.
It's a tiny shadow who's gets a tiny shadow.
Because it may be laryngeal, we thought it laryngeal, but X-ray shows a large mass. So we know means it is thymus only, and we repeated the X-ray 10 months, the same shadow. Then finally we confirmed it with the USG. So we confirmed the thing with the USG. Then we got it is thymus only, later disappeared. So ideal mutation mass, you are thinking about 3 T's: thyroid, thymus, and teratoma. So you are thinking about that terms. The posterior mutation, neuroblastoma, neurofibroma, and neuroclastoma. Recently we got a series of teratoma from posterior mutation. And a middle mutation, you got a lymph node and a pericardial bronchial system. So these are some of the localizing value of which area. So lateral exam may be very helpful, but nowadays, as we know, we are seeing CT scan, MRI, everything we are doing it, but it is only academic only. But you have to take X-ray. You can confirm it with the CT, MRI, but you have to use your clinical skill. You take an X-ray, interpret it, then you take CT, MRI. That is my request. Sir, it is okay, sir.
I think Dr. Anand, you hit the right point. Let me give an example which I have come across. I think I have shared several places. One patient from Veeravar, which is nearby Porbandar, Mahatma Gandhi's birthplace, was moving around, I would say, since long. So many X-rays, even CT scan once was done, sonography was done, this opacity, for opacity. Somebody said it is lymphoma, somebody said it is diffusion, even in CT scan. And believe me, lateral plate was showing that the shadow is in the posterior mediastinum. Absolutely. Here I think as thymus you are showing, take the lateral plate. And that suppose is the anterior superior mediastinum, very clearly it is thymus. The patient which I am discussing, posterior mediastinum, I went for the biopsy, turned out to be neuroganglioma. Because posterior structures are always with the sympathetic chains. So what actually that table Dr. Anand has shown, very important, that decide first the anatomy, and from the anatomy you can define that which structures are located there, which structure can give rise to these shadows. I think that would give the answer. Sometimes CT may not be able to give, because ultimately all the shadows somebody has to interpret. Interpretation is not right, you will be misguided. Therefore, I think this is a very good important table, that anterior mediastinum most commonly thymus or even the thyroid teratoma, and middle even lymph node. Please remember, this congenital malformation point of view, this lobar emphysema is most common in the left upper zone. Pulmonary sequestration most common left lower zone, and bronchogenic cyst most common at the right middle, I will say right hilar region. Even from anatomical location, you can try to think and get the diagnosis. This is very important. But suppose even the 6-month-old child is having some congenital heart disease and thymus is not seen at all. Thymus is absent. And I'm not clear whether it is cyanotic or acyanotic. What I should consider? My point is, absence of thymus more favor the cyanotic heart disease. Yeah, particularly D-Reiger syndrome, the may present with hypocalcemia, tetany, something like that, and even immunodeficiency disorders, So I think, these are the points how you can keep in mind. Yes, Dr. Anand, I think this is very important table for the students and even for the practitioner to keep in mind. Thank you very much. Please go ahead. Dr. Anand, you are muted. Dr. Anand, unmute yourself. Unmute yourself.
Now
Yeah.
we are going for some question answer session with the real viva. Because now we are coming to the point, so I can cover more exercise without much details. So, normal child, just you are take. Somebody take an X-ray. My surgeon take X-ray. Initially, I told him why you are taking X-ray. Later, I recognize that it is very good. So I can ask. I'll go in order. Bhargava.
Right cervical rib.
Very good. Cervical rib. Exactly. So you can see with the close cervical, large cervical rib here. My question is to next one, Chinmay.
Yes, sir.
Normal child. Bhargava, you can.
Sir, there is a difference in the level of diaphragm in both sides.
Partial cervical rib, right?
No, here also you can see cervical rib. So it is incomplete cervical rib.
Oh,
Whereas the other one is, so you make it 2-3 types of cervical rib. Partial, total, and a ligament cover. So it is a total here, complete. Here you can see only very small segment here, cervical rib. So this case we miss it. But other one may keep examination for examination. This one I think they won't keep for examination.
Dr. Anand, may I take the one point with this previous slide? I think somebody, I'm not sure who was speaking, some different level of diaphragms. I think Chinmay, did you say?
yes, sir, I said that.
Yeah. Now, what is the normal level of domes of diaphragms? The normal person, normal X-ray. Whether they are at the same level or some difference of levels. Right and left dome of diaphragm.
Sir, it should be at the same level, provided there is like, if gastric bubble is showing.
Neha, what is your idea? Normally, I am asking the normal person, dome of diaphragms on chest X-ray. Okay,
Right dome is upper. Right dome is upper than left because of the liver.
Okay.
Left is slightly lower because of the heart sitting on.
Even my question is also answered by that it is due to the liver. And I think Neha said something else. Yeah, what did you say?
So left dome of the diaphragm is slightly lower because heart is resting majority on the left side of the dome.
Absolutely. It's most common answer what I'm going to say. That the right dome of diaphragm is elevated due to the liver, but then immediately I'm keeping the next X-ray when I'm discussing situs inversus. When this liver and these are changed, and then what happens on the dextrocardia particularly. And in that case, what happens that the right dome of diaphragm is there. So what is the answer? That due to the persistent pulsations on the left side, left dome of diaphragm is displaced downwards. Right dome of diaphragm is just normal anatomical level. And if you go for dextrocardia, you will get it that here the right dome of diaphragm is at lower level. Right. So I think somebody is asking, at least you can answer. Thank you. Dr. Anand, please.
Okay, thank you, sir. So next question to Anna Roy. So serious child, toxic child.
So consolidation and pneumatococcus staphylococcal
So it is a very characteristic shadow. It is a bulging fissure.
fissure.
So it is
Bulging fissure.
Klebsiella pneumonia. So it is a sign of Klebsiella pneumonia. You can see here cavity also. So Klebsiella pneumonia. Okay, next one. Large head seizure, but he is very fond of in music.
So
Question to Neha.
So we can see the VP shunt here, sir. Large head with seizure, probably a case of operated case of hydrocephalus with VP shunt in C2 on both sides, bilateral.
So it is a bilateral shunt, simple, but out of curiosity, usually you get a shunt on one side, but here it got a bilateral. So we'll go to the next one. What are the findings here? Then we need it.
So there is a right-sided complete opacification seen. Then gastric bubble is seen. Sorry, left-sided hyperinflation is seen. And
So you have the three findings here. One is a bifid rib, tuning fork rib, you can see here. Here you can
Bifid
see
rib.
hemivertebra, the total agencies of lung. So very interesting. So that is why I mentioned it. Don't happy with the one finding. You have to look for whenever there is a congenital anomaly, you get a multiple anomaly. You have to look for like that. So here it is bifid rib. Then you can see hemivertebra, and it is a agencies of lung. That is why you got here complete hyperinflation. Very good. And next one to Bhargav. Very simple X-ray.
Hyperinflation.
Hyperinflate, bilaterally hyperinflate.
Hyperinflation.
Absent
That is
clavicle.
asymptomatic.
Absent clavicle.
Clavicles are absent bilateral.
Cleidocranial.
It's a bilateral
Yes.
absence of clavicle. So maybe clavicle kind of resources something like that. So it's a very good X-ray.
Can you just, Anand, go for the previous section?
Yeah.
Just a small point to the student, whether this X-ray is taken in erect posture or lying down position. Can you make the comment? This X-ray is taken in erect posture or lying down posture?
Erect.
It's an erect posture.
Erect.
Why?
Because
have
gastric
eye?
bubble, fundus bubble,
Because-
there is a
Diaphragm is almost flattened and it is pushed down.
Yeah. Rather than push down, you know what happens?
Um,
It is dispersed with the fluid. So may not be showing this sharp shadow in the stomach, just I will say below the dome of diaphragm. And that level should be, suppose this level is few millimeters usually. Opacity between this fundus shadow and the dome of diaphragm. But suppose if it is few centimeters opacity, what it can be? That means very definite opacity is sitting between the lungs and the stomach gas shadow. Then what can be the differential diagnosis of that opacity? Opacity is only at the base of the lung, nowhere else. Anything comes to your mind? And even patient has some respiratory symptoms also.
Event.
Hiatal
Hiatus hiatal hernia.
Sorry, Vinny?
Hiatal hernia.
Hiatal hernia. Hiatal hernia.
Hiatus hernia, but you know hiatus hernia will give this opacity paraesophageal. Here I am talking just about the gas shadow. What is my point? It's a subpulmonic pleural effusion. Subpulmonic. And what Dr. Anand was talking, if you go in the lateral decubitus, that fluid will be traversing on the lateral chest wall. That even you can see. Dr. Anand, you can take it further.
Okay, thank you, sir. Thank you for the valuable comments and new information, sir. A cerebral palsy child is suspected aspiration. We are taking X-ray. So I will ask Chinmay, what's the X-ray findings here?
So both the hilar regions appear, so hilar opacities are present.
So you don't take a so seriously because the X-ray, because of the cerebral bedridden,
Exposed.
quadriplegic child, you can see a X-ray. But here
Look.
just concentrate on head of the humerus. Here you can see rickets.
Look at the bones also, yes.
Bones here. So you can
Yes.
see head of the humerus is a widely rare, just like our rickets in the wrist. Here it is humerus. So in rare X-ray, you can see such a large, irregular, large head of a
Yes.
human. That is why I told you, chest X-ray, they will give you more bone X-ray rather than chest X-ray. You have to look for bone part, you get confusion.
Dr. Anand, here only one point, please, for the sake of the students with this X-ray. Many a times this X-ray is kept, most of the people will say it's a dirty X-ray, it's not clear X-ray, I cannot give the opinion. But I remember my teacher used to answer, the good person should be able to find out the diagnosis from the dirty X-rays. And I think here the X-ray, if you try to see, it is not the clarities in the structures, but I think very important. Yes, Dr. Anand, take it further for the rickets, please.
Yeah, my question to we need Anna. So what are the cause for rickets in CP? Because usually
Reduced
it's-
sun exposure,
Yeah.
malnutrition, and reduced sun exposure, sir.
But the most important. So
Yeah.
it may be lack of sunlight exposure,
Poor diet.
poor diet, bedridden, because you get
Bedridden.
last one. Anybody?
Multiple anti-epileptic therapies.
Yeah, definitely.
Absolutely, absolutely. I think very good answer,
think-
very good answer.
So these are the 4 causes for rickets in SCP. Usually it is a disease of the growing bone, but too much bedridden, you may get such changes. So 5-month-old child, it is with severe anemia, dyspnea, and splenohepatomegaly. To be frank, it is a case of consanguineous marriage also. The child got severe pala, splenohepatomegaly, dyspnea, and breast cancer. We have taken chest X-ray. We got a murmur also. It may be due to anemia. I am not that much of history. I not mentioned. All these things are published cases, published in the IJP also. And here you can see we are taking X-ray. This child is dysnic. We got murmur also. But heart is normal, lung is normal. But we are very happy. Neha.
So all the bones appear very hyperdense, suggestive of like osteopetrosis, where
Very
the
good, super.
blood is
Very good, very good.
So it is
very good.
osteopetrosis only. So you can see that actually you can see the white bone here, and it is osteopetro. That is a population osteopetro rickets. This is a case of osteopetro rickets. Okay, so chest X-ray will give so much clue. We will come to the later also. So many X-rays coming. So we will get so much clue from chest X-ray. CT scan, MRI won't give such much clue. Initial clue you get from chest X-ray alone. We need it is a bystander, asymptomatic bystander. I had given money to take an X-ray because of my personal interest.
So here we can see left-sided hyperinflation congenital. Sorry, emphysematus.
Huh?
Left-sided emphysema.
Pectoralis major.
Which side is abnormal, left or right? Which side is abnormal? That is abnormal.
Left side. Left side.
Left side.
Left side is
What is it?
Left
Is pneumothorax?
colon.
Pneumothorax? Anybody?
Pollen syndrome.
Pollen
Pollen syndrome.
So it is a pollen syndrome. So it is you can see that because you want to get 2 types of exposure in the body. X-ray not possible to take like that. So here more penetration on one side, that is left side. So some anomaly I had seen that in the body of that child. That is why I have taken X-ray. So it is pollen syndrome. Then they will ask what is a heart anomaly associated with like that. They can ask question like that.
Even why there is hypertranslucence in pollen.
Sir?
But I think to the students, the pollen syndrome, why there is a hypertranslucency on that side.
Absence of muscle.
Yeah, absence of
Pectoral
which
muscle absence.
Muscle
Which
mass.
muscle?
Muscle mass
Pectoralis
is
major.
pectoralis major.
Absolutely, absolutely.
So which other condition you get such X-ray? Which other condition?
Yes, you can give the even BT.
Amastia, mastectomy.
Yeah.
Mastectomy.
Yeah. So here you can see severe pneumonia. You can see multiple pneumatophily here. Okay. So we'll go for next X-ray to Bhargava. So what is it? Same X-ray,
I
same
am
patient.
seeing a subcutaneous emphysema.
Yeah. So
in
you
a
have to look outside the chest also. The subcutaneous emphysema.
ICD.
Cavity is there. Cavity,
infection and,
endocrine, everything is there. But you can see compare this side with this side. Very good. So it is a multiple. So all you should take a MD pediatrics, not a radiology. Okay. This child is a newborn. I think simple X-ray.
Oiling of
Tracheoesophageal fistula. Okay. Simple X-ray. Tracheoesophageal fistula. Sudden onset of dyspnea. So here foreign body, it is on left side
Foreign
only.
body.
So it is
Left
a
side
foreign body,
hyperinflation
trapped lung here. So it is foreign body only. And here you can see large long form emphysema on right side. We already shown some case. That is why I'm rightly going that. Recurrent fever under cough, you can see large cavity, large bulla-like lesion. So it is a lower emphysema. This X-ray, it is CHD. What is it? We need.
TAPVC.
Anybody?
TAPVC.
It looks like an operated case, so we can see a device closure used.
Very good. It's a PDA.
Very good, very
PDA
good.
closure point.
We got so many X-ray like that, but the cardiac X-ray personally avoided, but one or two came in between. That is why the problem. We'll have a cardiac bone X-ray later. Sorry for including cardiac X-ray here. And a fever of 2 weeks duration. Fever, 1.5 fever of duration.
TB, TB, TB.
TB.
Mediastinal hydral adenopathy.
TB.
So you can see multiple bone lesion here.
Osteolytic regions. Yes, yes.
So it is histocytosis. We got so many X-rays, so many X-rays that are there. I not shown only chest X-ray I'm showing here. So we got so many X-rays with the findings. So severe pneumonia here, and again it is a subcutaneous emphysema. A large baby, incomplete Moro. I think Anna can answer. Large baby, newborn, and incomplete Moro.
Clavicular
trauma.
fracture, clavicular fracture.
Yeah, it is clavicular. That is a callus here. Very, very beautiful callus here. So it is a callus formation. They'll complain for the swelling, not for the fracture. Rarely they come for fracture. Otherwise, they'll come for the after 1 to 2 weeks. They'll develop a callus. They'll come with the swelling. Actually, there's no treatment needed.
Dr. Anand, just one correction for the students.
Yeah.
You know, in the clavicle fracture, there is the asymmetrical Moro. While in a case of premature baby, it's an incomplete Moro.
Incomplete Moro.
So you should be able to understand incomplete and asymmetrical, because somebody may ask you. Okay, please go ahead. Dr. Anand, you are muted.
So we have proceeded.
Yes, sir. Please.
4-year-old child with history of recurrent fever, recurrent pneumonia. So what is this swelling? So here you need some extra investigation. And the same sort of persisting for a long time. It's a bronchogenic cyst. We confirm it is bronchogenic cyst. CT MRI is there, but I not shown. So the X-ray, same X-ray was there. So bronchogenic cyst. I can see large cyst here is there. And fever and cough of dyspnea, fever, cough and dyspnea. It's a 2-month-old child, Neha.
So we can see a circular
mass.
Yeah.
Lung.
Ambulance, spacer.
Yes, sir.
It is a tricky X-ray. Okay, I should not ask question to you. So sometimes you have to see in the back also.
Hydrated.
So you have to see the back. It is just a meningocoeli only. But when somebody interrupted the X-ray, but they not look in the back. So it is just a physical shadow only. It is not for examination purpose, but we are coming to the end of this. That is why.
Even for the sake of students, sometimes you will get the shadow, something there on the table, even nothing else. I know
Artifacts.
sometimes I've seen the X-rays, some artifacts, even some shadows is there. So I think and that's why here it is back some other soft pathology.
If Baldev sir allowing, I'll show artifact, chest, CVS X-ray, DAT X-ray, bone X-ray, newborn X-ray in next class. Okay.
Yes.
So finally, my dear students, you avoid unwanted X-ray. Don't take too much X-ray. If there is fever or cough, wait for 3 days. Otherwise, you have to repeat X-ray. Otherwise, you have to, because one condition where we are repeatedly doing X-rays, only one is asthma. Asthma, we are going on X-ray. And also, upper respiratory tract infection. And also, you have to avoid extra exposure also. So you can see here, it is a June 9th, they are taken X-ray for fever and cough and wheezing. We don't see any shadow here. And again, June 11th, they take another shadow after 2 days. Here again, there is no much shadow. And here again, they are taking another X-ray. So it is radiation treatment of asthma. So such things you should not do it. Don't take X-ray in the case of asthma. If there is a confusion, initially you can take one X-ray. If you are expecting any complication, you can take it. Otherwise, don't take X-ray. You will get confused. You first give you antibiotic. All this shadow, it is there in asthma. So don't take X-ray in the case of asthma. Don't give antibiotic. And another thing you can see here, the whole body, even testis, ovary, whatever it is, complete body is exposed. Because radiographer don't know what to do, what not to do. It is we have to judge them. One is number of X-ray. Second is the area of exposure, including actually this you can see here lower down. So you can see such things. 15 X-ray, 15 days, 11 X-rays. I have no place to keep the X-ray here in a single snap. That is why. So such things you should avoid. You are a budding pediatrician. You have to see all these cases. And thank you for the patient hearing. Thank you, Baldev Prajapati sir, the great teacher, for being with me throughout the time. And also, I personally thank the organizer of e-Gurukul, especially Yogesh and the madam and Neha Patel. It is our Trishu Puram, very beautiful. I think Anna may know it. Anna is my student from BBSc in Trishu only. Now only because as sir mentioned, I study in Surat only. Now my student is studying in Surat.
Yes, that's good. That's...
Okay, sir. So I stop sharing.
Yes. So I think the students have really enjoyed this session, and we are actually got a few more minutes with us because our session is from 6 to 8. So sir has taught us so much and shown so many X-rays that I think all the students are really going to get interested in pediatric radiology and may take it up, I think so. But only one thing which is usually asked in your DNB exams is the exposure that a single X-ray is given. What is the unit which is there? And how much is the difference in the CT scan exposure and the exposure of doing what sir just took us, that avoid taking too many X-rays because we don't know what happens after 10 years, 20 years, 15 years. So be careful when you ask for the X-rays. And sir has given so many messages like radiological changes take time to disappear and the clinical changes come earlier. So we have had patients where X-rays have remained abnormal for 2 to 3 months also. And people, when they hop from one doctor to the other, every time the X-rays are taken. So what the take-home message from this session is not just exam-oriented, but when you start your clinical practice, try to do the least investigations, concentrate on more on your history taking and physical examination and very focused investigations. So there are many things which we could take back from this session. I also learned a lot from sir today. And also gathering X-rays, I think so, is a hobby for Dr. Ananda sir, because he collects them and then puts it in the DNB exams. Okay, he is an expert in OSCE. He may not tell it to you, but maybe you will get it in the DNB exam, his X-rays. So if there are any questions from the students, because it was a rapid session because we had to cover so many X-rays which are of practical importance. So do you have any questions? And there is a chat box also down. If the people who are watching this session and if you have some questions, because we do have another 10 minutes or so.
Chat box it is not visible for us. No? Chat box only we 11 people can visible.
This chat box?
Other audience they have to.
No, I think
post it.
ClearNet people. Rupsa, can you just have a look at it? In the meantime, if there are any questions from
Anyway, madam, our students are very good. They are performed very well.
very well.
Also, if you have any further doubt, you can read my IEP textbook of pediatric radiology by JP Brothers, first edition. So now it is second edition. Also about to sold out a very good textbook. And I think Baldev sir, any comments? Sir?
Yes.
I think before I go for the comment, let me congratulate Dr. Anand. Fantastic, I will say, session which he has conducted and conducted also very nicely. And even all the students also participated very actively. To be very frank, in this session, I could see that everybody was trying to answer. And as Dr. Anand said, most of the, I would say, your responses were quite appreciable. I understand to see the X-ray first time, at least to look at the X-ray, to find out some abnormal findings, and to answer requires some time for the thoughts. I understand. But still, I will say responses were really quick, very prompt, and very appropriate. So I'm sure that this performance of all the students were very good and the whole session was good. The only thing what Dr. Aarti Madam said, please remember so many times we have discussed in the past also, any X-ray, any CT or any MRI or sono, I will say any modality of investigations, even laboratory investigations. Before you go for the any investigation, you should have the detail of the history, thorough examination, and at least functional or clinical diagnosis before submitting the patient for any investigations. Many times, as Dr. Anand said, I'm asking my students, they go for the X-ray, that what was your idea, what you wanted to see. Or suppose if you go for repeat case X-ray, Dr. Anand said, absolutely, what is your, ask these questions to yourself, that why we want to repeat it. You know, simply if you take in a case of pneumonia, when we go for repeat chest X-ray, on the contrary, you know, I think Dr. Anand already has discussed that, you know, for diagnosis of pneumonia, they say even the X-ray is not required. But okay, but suppose once you are diagnosed, repeat X-ray hardly requires. Even not for confirmation that it is responded. You have started the antibiotics, appropriate, 72 hours, patient is improving, and due course of time, 5 to 7 days, patient has recovered, no repeat chest X-ray. But after 72 hours, suppose patient is not improving, rather than going for changing the antibiotics, think for the complication. And for the complication, you may go for the first X-ray. And suppose further you are getting some idea that there is some necrosis or some collection of fluid or development of some complication, of course you may go for USG or CT, whatever is indicated. I think what I mean to say, you should have the ideas, not just because it is available or just you wanted to see. And I think therefore what Dr. Anand was conveying the message, unnecessary repeat X-rays, unnecessary radiation can be cut down. And many times not necessary every time this it is answering. It may misguide you also. So please, any investigation, we should not go further. Of course, these available modalities, what Dr. Anand was saying is absolutely right. When we were students, even never seen the ultrasono. Even CT, that just if you write down CT, examiner will be so happy that, oh, he has mentioned the CT in the answer paper. So much even. We were trying to imagination. I remember one of my surgeon's teacher asked me, because I have written the USG, sir said, what is USG? I said, don't know, but some rays will be coming and that rays will give some different shadows. And from the shadows, we'll understand that what is it. And this was considered a very good answer. But you know, from that we have come. And Madam will also agree with me, Dr. Anand will agree with me. And at one international conference, when I said that we were unfortunate, but now we are fortunate that we didn't have the much options. So it was compulsory for us to learn these basics, history, examination, clinical medicine, and then very basic investigations. And from that, probably we could learn the good medicine. But I would say this generation, you are most fortunate. You have even the more facilities, but the only one dangerous point, utilize all these gadgets appropriately. As we are talking with the mobile and laptop, you know that there are also hazards to the children. I think these are also hazards to the clinicians. So not necessarily every time you are getting the help or answer. Many a times, knowingly, unknowingly, we may invite the trouble or we may damage the patient. Definitely, appropriate use has increased our understanding and so many things we have learned. So in short, balance utilization of this modality we have to learn. Thank you very much. I would say, at least give me this opportunity. As Madam said, Dr. Anand, absolutely, I learned many things. And as Dr. Anand said, I have also more than 300 X-ray collection from my days of residency. From my days of residency, 83 even, I have these X-rays. And that later on, it was just I was showing on the view box to the postgraduates, the exam also. Then I got collected almost 15 years back in this PPT. And in one pen drive, more than 350 X-rays are there. I think now I will remain in touch with Dr. Anand. We learn from each other and we'll go further. And Dr. Anand, I have that your book, probably in my library just now, that IAP book on radiology, and I'm reading it. And I'm sure that the students should read it. You will learn so many things. Thank you very much, madam.
Yeah, making presentation and writing book is best method of storing our collection. Otherwise, we'll miss it.
Absolutely, absolutely.
Neurology, I started writing so many articles, then finally I published 2-3 books.
Yes.
Like that. Madam, you are from Pune, madam? Are they, madam?
Yes, BJ Medical College, Pune, professor and head of pediatrics.
Madam is head of the department there.
Yeah, I am coming to Pune last week, madam. This last week I am coming. 27 and 28 are coming to Pune.
You're coming?
Yeah,
do visit us, sir. Do visit us at BJ Medical College.
I'll get your phone number, madam.
Yeah, sure. I'll send it. I'll send it, sir.
Dr. Shiji is my student. Dr. Shiji, she's in the
viva
Patil Institute.
Viva Patil. Yeah, neurology.
Just like Anna, she is also my student.
Okay, that will
just I wanted to show the book to the students.
Yeah, I just first madam. I just sold out. Now it is second, madam. Second is full. Thank you, sir. Thank you very much for the encouragement.
We can expect a third edition with your book and Dr. Prajapati sir's.
Sure.
I think so. That will be the best encyclopedia then.
Yeah. Thank you, madam.
I'll take this opportunity to thank all our 6 participants. Dr. Bhargav, Dr. Vinit, Chinmay, Anna, Neha. Have I missed somebody? No, I think that's so. Thanks. And I think you, as sir said, you have all passed with flying colors. So I'll thank Dr. Prajapati sir, without whom I think so it doesn't become very clinical and sort of interactive. Dr. Ananda sir, who has taken so much efforts to put everything together, make it interesting, question answers, and finally the table viva, which you have scored 100 out of 100. I think so. I will hand over to Clarinet because today we don't have Dr. Yogesh Parikh sir because he usually gives us comments. I think they're on their way to Mumbai for the IAP meeting, and also Dr. Nehal. So thank you everybody, and also Clarinet. Thanks.
Ma'am, can I show the expert certificate?
Yes, yes, please, please. Okay. So please, yes, please accept it on behalf of eGurukul, and we are very grateful to you, sir. Thank you so much.
Okay, thank you, sir.
So we take your leave, and We'll see you on next Saturday with another session of eGurukul. And those who are listening and are interested in joining for case presentations or seminars, please come forward, because we want more and more people to take benefit of these sessions.
I think only one appeal to all the students, that please participate very actively in this type of the sessions. That will be definitely quite rewarding. Even in the future also, whatever the case is or whatever these sessions are kept, whenever you get the opportunity, you remain present and even encourage your friends. I'm sure that even all of us are mutually learning, not only the students, we are also learning. So I'm sure that your participation will help us a lot. Thank you very much and good night.
Okay, thank you. So we'll end the session here, and a happy Sunday to all of you.
Thank you, everyone. Thank you for
Thank you.
sharing such valuable insights. We are more than grateful to everyone present here. We hope to have you again on our platform very soon for our next session. So with all your permission, sir and ma'am, I would like to sign off for today. Have a nice day.
Thank you so much, Rosa.
Good night.
Good night, everyone.
Good night. Good night.
Hello. 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 Rupsa ma'am.
Yes, ma'am.
Regarding the previous videos, ma'am, where can we get it?
Okay, ma'am, that will be uploaded by next week on YouTube.
But ma'am, last I think around 1.5 months video, they are not yet uploaded. We have an exam upcoming, so we were thinking if these videos would be helpful for us. So
Ma'am, that will be uploaded by next week for sure.
can we get your contact number?
Ma'am, for that you need to contact Onanya, ma'am. Okay.
Online number, any contact number?
No, I do not have her contact number actually.
Email ID?
But you need to contact her because I'm not in charge of that department. Okay, ma'am. Bye. Have a nice day.